Well, again, thank you for the invite. Thank you for this opportunity. And really, as a urologist, I've learned a lot collaborating in a multidisciplinary setting. And obviously, this was led by primarily one of my colleagues in radiation oncology. So talking a little bit about our experience at UAB in terms of establishing focal SBRT as a potential option, but more right now as a point of investigation. So I'll be discussing our UAB RAD 1801 trial, which is registered as a National Clinical Trial Registry. It's a single-arm interventional trial entitled Pilot Study of this Intraurethral Transponder Beacon Guided Focal Prostate Stereotactic Body Radiotherapy. So one of the novelties of this really is the intraurethral markings with these calypso beacons, allowing for electromagnetic shutoff if there's any motion or distortion of the actual target area or the prostate. Our project accrual is 10 patients on this pilot trial, acknowledging it's an early pilot. And it has been designed to allow screening and consent for up to 15 patients to allow 10 to hopefully go through with full 5-fraction therapy we'll talk about. We just started, despite about 2 years of engineering and design, and we'll talk about the actual mechanisms by which we've got this going. But I'll talk about some of our early accruals and hopefully in the future discuss data that comes out of this work. So our patient characteristics, patients with low to favorable intermediate risk disease as defined by up to grade group 2, PSAs less than 10, and only up to clinical T2A stage. So the patients either had MRI and subsequent targeted biopsy with positivity of less than 50% of the volume of the entire gland that we would be targeting, or in patients, we would allow MRI-consistent lesions in the area of a systematic biopsy that was mapping, which was, again, allowing for positivity of a treatment area up to half the gland. No clinically significant prostate in any non-overlapping sextants, whether it be the ipsilateral or contralateral side. And the patients had to be eligible for transurethral 16 French Foley catheter placement and removal on multiple visits. These are for the simulation scans as well as each of the 5 fractions. So exclusion criteria, we did not allow for any patients with more than 2 MRI lesions, which were biopsy proven on targeted biopsy. No hemigland, in excess of hemigland treatment was planned, so our goals were to treat less than or up to 50% of the prostate volume, and then the exclusion criteria seen listed below. So our primary objective is to confirm technical feasibility actually of these intraurethral transponder beacon devices. This comes off of the fact that many of our centers are doing SBRT for whole gland therapy. A lot of our SBRT actually integrated simultaneous integrated boost field, which is where the concept of this came out. We were doing 5 fractions and standardly do up to 36.25 gray to the whole gland, and up to 40, sometimes 42 gray to an area predetermined within that same zone of the prostate, but targeting the area that was enriched by biopsy, typically in an MR-guided way. Then we built on that, why treat the entirety of the prostate? Let's move this to a focal arena. The issue was the fact that all of the patients undergoing SBRT with that simultaneous integrated boost at our institution had fiducial seeds placed through a transrectal or transperineal approach into prostate tissue. Subsequent follow-up imaging, we understand, would obviously be altered by those tissue-placed fiducial markers. So our goal with this study is to introduce a transiently placed transurethral fiducial markers and see whether the feasibility of that allows to get great focal therapy, but more so allow nothing to be in the tissue of the prostate to allow for multimodal imaging down the line. So our secondary endpoints, early clinical efficacy, treatment toxicity, and quality of life, just for completeness, understanding it's a pilot trial. Our treatments are 40 gray to the area up to 50% of the gland as marked out, 5 fractions. The fractions are spaced every 2 to 5 days with all fractions intended to be completed within a 14-day period. So our treatment planning all relied on multiparametric MRI and targeted biopsies. We have the DynaCAD software platform, which was used for mapping of the targeted biopsies, and then employed MRI to CT fusion using the Varian's proprietary area planning software. And using for that, we have multidisciplinary consensuses for developing optimal margins, and those are optimal margins we defined as 5 millimeters anteriorly and lateral to any of the focal targeted lesions and 3 millimeters posteriorly if it was in the peripheral zone. All margins would be limited based on constraints of cold zones defined by the urethra if neurovascular bundle was considered and the sphincter. So our engineering feat that took about 2 years was allowing for real-time mapping using Calypso beacons, which were placed essentially into a Henschke catheter transluminally through the drainage port or drainage channel of a standard 16 French Foley catheter. So both of these images are demonstrating cutouts of the design of how we've made these Calypso beacons instilled in the catheter. Our follow-up, just to get to the patients, we've screened 3, 2 have undergone simulation, both have tolerated simulation, and based on the dosimetry, we have had 98% coverage with 40 gray of the entire area that was marked. 1 is currently on treatment, and our plans are to assess these 10 patients that hopefully will be treated moving forward with PSA follow-up per standard, as we talked about, biopsies that we are doing mandatory at 12 months, but also follow up optionally at 24 months. Our goals are to evaluate in-field and out-of-field persistence and existence of disease respectively, and then retreatment rates, whether it be with focal radiation, other modalities, or Hoagland therapy. Can't do this without a whole team, and I hope to present fuller data in the future. Thank you.
Thank you very much.